until I open the cases. The case should be here. Yeah, the case is there. I'll just open the timer. Sorry, I will just be 1 second with you, doctors. It's just taking time for me. Yeah, 12 minutes. 3 minutes. Someone can volunteer, please, to admit the doctors until just I finish preparing the timer, please. Okay, yeah, the timer is ready. Yeah, it should be fine now. Yeah, you can see if there's anyone in the lobby. No, all are admitted. Okay, I'll share my screen. Yeah, screen should be shared now, and then I will open the case. Yeah, can all of you see the case? This case there? Yeah. No.
Yes.
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 Okay.
Yes.
That's good. That's good. That's good. Excellent. All of you slept good today before coming. Yeah. You feel how is the work, everyone? Hope everything is fine in the work. Okay. Let's see. I will give you the 3 minutes. Okay, it's a three A4 okay worth of reading. Okay, so whenever you reach the bottom of the first page, you just let me know to scroll it. Okay, Sophia?
Okay.
And the rest of the doctor also, I hope you can also try to read and time yourself how rapid you are in the reading. And also take a note or what you can extract, important note, what you can extract from the story of the patient. Okay. So like that, all of us will learn. Okay. I will start the 3 minutes. Shall I go down, Sophia?
Yes. Yes, that's fine. Can go down.
Do you want me to bring it somewhere? Put it up, down?
Yeah, that's fine.
Huh? Are you happy to start?
Yeah, that's fine. I'll start.
Okay, you can start.
Hello, I'm Dr. Amjad. Is that John English?
Yeah, doctor, thanks for calling.
How can I help you, John, today?
Well, I think to make the, I'm not sure, doctor, I received the message that you want to discuss with me the results of my
Yeah, so
blood and stool.
so yes, John, I've got the results with me. Do you want me to take through why you had these investigations at first place?
Oh yeah, to be honest, doctor, it's have been awful, to be honest, doctor. It's have been I think 5 or 6 months where I have these pains that it's never going, you know, in my upper part of the tummy. I came to your colleague and he gave me some tablets, and then the tablets I see, and he did some blood tests, but the tablet is not working, to be honest. It's not working properly.
Hmm, right.
So
I'm
I
sorry
still
to hear
have
that.
these pains.
I'm sorry to hear that you're having these kind of pains. Has anything changed since you last saw my colleague?
So like what, doctor?
I mean, do you think this pain has gone worse?
Um, no, not worse, not improved. I mean, it's the same.
Hmm, right. And where exactly the pain is?
Well, the pain is in the upper part of my tummy, doctor.
Right. Okay. And is it all the time or it comes and goes?
But no, it comes and goes usually after meal, doctor.
Mm. And when it starts, how long it lasts for?
Well, it depends. Sometimes we'll stay for half an hour. Sometimes even we'll stay for more than that. Usually, I'm taking some milk to help with the pain.
And does that help with pain?
Yeah, a little bit. Yeah, but it's just annoying, for how long I will keep having these pains.
Mm, I mean, that's hard. It looks like you're going through a lot. Um, and does this pain go anywhere at the back or up along your throat?
No, not at the back, but it's going, yeah, I feel some burning sensation sometimes, burning feeling, like heartburn in my chest, and it go to my throat because I think also your colleague asked me that, and yeah, I do get these symptoms.
Right. Yes, I can see the notes I can see the consultations you had with my colleague. So you mentioned like it does go to your throat. Um, have you noticed any trigger apart from you mentioned like it happens after food intake, but have you noticed any other triggers?
Like what, doctor?
Have you do you drink a lot of caffeine or alcohol?
Oh, yeah, well, I'm accountant, so I'm always drinking coffee. I can't work without coffee, to be honest, doctor.
Hmm.
Well, alcohol, I don't think more than usual. I'm drinking socially.
Right. Okay. And how is your diet? I mean, do you eat a lot of spicy food in your diet or?
No, not particularly, to be honest.
Hmm. Okay.
I'm trying to eat healthy. I'm trying to eat fruit, vegetables. Nothing in particular, but maybe I'm having, the odd chocolate, but every week or something. I like chocolate.
Right. Okay. And have you noticed any any weight changes at all?
Weight changes. Well, yeah, I'm trying to lose weight, doctor. Yeah, I'm doing exercise,
Hmm.
but not
And
massive. I hope I lose weight, but it's not massive.
have you noticed any unintentional weight loss at all?
No, no.
Hmm. Okay, that's good. And do you smoke?
No, doctor, I'm not a smoker. I don't smoke.
Hmm. Okay. And you mentioned like you're managing to exercise, and I mean, you said you're accountant. Do you get enough time to exercise during the week?
Oh yeah, doctor. Well, every day after I finish my work, I'm going. I'm returning back home walking, so it's like 20 minutes walk. Okay,
That's
and
good.
also in the morning, yeah, my friend will pick me up, but in the return, I'm doing that, and then over the weekend, I will go for the gym.
Right. Okay. Right. Well done. That's good. And you mentioned like you're not smoking much. How much you're smoking?
Oh, no, I'm not smoking, doctor.
You're not smoking. Okay, I'm sorry.
No, no,
Right. Okay. And do you get sick along with this pain at all, or do you feel nauseous?
no, no, no.
Okay. And I can see you are on medication, sertraline. Are you still taking it?
Oh yeah, doctor, I'm taking it.
Right. Okay. So, what do you think, John? What do you think is going on here?
Well, to be honest, I'm not sure. Your colleague told that he will test me for a bug or something, and I had a look at the NHS app, and it's saying that I think I have bug or something in my stomach.
Right. Okay. Yes, we can talk about it, John, today. But before we talk about this, you mentioned like you have seen in the NHS app and showing bug. So yes, that's right. It is showing a bug that is causing your symptoms. Um, are you worried about this at all?
Well, I'm not sure, doctor, if I have a bug from where I get it.
Right. Okay. So that's your worry. And was there anything else you were worried about apart from this?
Well, to be honest, doctor, I Googled it before I come, and they said that I can get a cancer from this bug.
Okay. Okay. Anyone in? I mean, like you mentioned, like you googled it and it came back as cancer. Um, anyone in the family has got cancer?
No, no, thankfully, no.
Right. Okay. And have you noticed any appetite loss at all?
No, my appetite is fine, doctor.
Okay. And you mentioned you have not lost any weight unintentionally. That's correct, isn't it?
Yeah, no,
Okay. And do you experience any night sweats?
no, no, doctor, no night sweats.
Right. Okay. So John, yes, I mean, as you mentioned, like it's been going on for 5 months, and you had some pain, and we have tried some tablets on you, but that didn't make any difference. So,
Mhm.
we stopped the tablets and tested and did a stool test on you. Like
Yeah,
you mentioned, it's showing a bug which we called as H. pylori. So it seems like H. pylori is causing your symptoms. So it looks like you're having kind of gastritis because of this bug, H. pylori.
oh, okay. What is gastritis?
Yeah, so gastritis is a condition in which there is like inflammation of the lining of the stomach.
Okay, okay. Yeah, so what we should do though, doctor, just
Yeah, I can see you are. I mean, like there. I know you're worried about cancer, but if we get the right treatment for this bug, and if it doesn't lead to cancer.
okay, okay. That's reassuring. And so it can lead to cancer then, this bug.
I mean, like the thing is, gastritis, if it's like left untreated for the long term, and if it's like if there is an inflammation of the lining of the stomach, and if we don't do any treatment for this, that can sometimes trigger cancer in the long run. But if we get the treatment for this bug, then it's unlikely to cause cancer in the future.
Okay. Okay.
And you mentioned you
Um,
don't have any weight loss, appetite loss, no night sweats, so that's reassuring. No family history, and you don't smoke. So well done for doing that.
okay.
Because these are the kind of risk. Smoking is a risk factor as well.
Okay. Okay. So what
Yeah,
we should
you
do then?
Yeah, I mean, like there are a few things which you can do to make your condition better. So you didn't, and there are a few things which we can suggest. So you mentioned like you're drinking coffee. I know it's hard when you're at work and you have to kind of maintain your alertness and you have to drink a lot of coffee to kind of work. But um, coffee is, I mean, coffee can trigger gastritis, so it can lead to
Mhm.
inflammation of the stomach. So it's really important that we think about cutting down coffee. What are your thoughts?
Yeah, no problem. Is decaffeinated coffee is fine, doctor.
Decaffeinated coffee is fine because caffeine is kind of irritant to the stomach. Yeah,
Okay.
yeah, okay. And then you mentioned you eat quite a lot of chocolate, so I think chocolate is another irritant which can irritate the stomach. So I mean, I think we have to think about cutting down chocolates as well.
Okay, will do. No problem.
Mm. And now that we know like your H. pylori is positive, are you allergic to anything?
Yeah, penicillin, doctor.
Yeah, I can see you've got like a reaction to penicillin. So, I mean, for in order to treat this bug, you will need treatment with an antibiotic, but it will not be penicillin, but it will be clarithromycin.
Okay.
So, you have to take this antibiotic and another one, which we call as metronidazole,
Mhm.
along with the omeprazole, which you had before. So, you need like combination of these three medications, and you have to take it for 2 weeks.
For how long?
For 2 weeks.
2 weeks? Okay, doctor.
So
Oh,
um because this is a bug, that's why we give you antibiotic for this. And then the other one is like a stomach protection tablet, which generally helps with inflammation of the lining of the stomach.
okay, okay. And then how will we know I'm this bug gone?
Yeah, I mean like the thing is like if we treat you with the medications, then we kind of hope that this bug is gone.
Okay, okay. So I mean,
Yeah,
you don't need to see my, don't need another stool sample from me after that, or what
I'm not
should I do
entirely
after?
yeah, I'm not entirely sure about it, but I can have a look in the guidelines and obviously I'll let you know over the phone whether we need to repeat your test or not.
Okay. So just doctor, I didn't get from where I get this infection, and do I have a girlfriend, did I give it to her?
Yeah, it's not a sexually transmitted infection, John. So, it's not gonna pass to your girlfriend. But the thing is, like, you usually get this bug through fecal-oral route. So when we say fecal-oral route, that means like sometimes if we are like eating outside and not washing our hands properly, that can lead to like that can cause our body to get this virus as well.
Okay,
So
okay.
hand hygiene is quite important. So make sure when you go to the toilet, you wash your hands properly. But
Yeah,
it's
sure,
unlikely
doctor.
to be, yeah, it's unlikely to be passed to your girlfriend.
Okay, okay.
At any point, if you get develop any severe pain in your tummy or get unwell, develop fever, just let us know.
Sure,
Oh,
sure. Yep, well done. So you tell me what you think did fine or what you think you did bad. Would you do something different if
I mean, I can't remember. Like, I think it's 2 weeks, but I can't remember the
no,
H. pylori
it's double dose for 1 week. Okay, so double
double dose.
dosing, yeah, it's double dosing of the medication for, I will show you the slide. Double dosing for 1 week. Okay, yeah, so double PPI and then the dose of the antibiotic to be the higher dose of the antibiotic, 500 clarithromycin twice and 400 metronidazole twice a day, and then the PPI 20 or 40 omeprazole twice a day for 7 days. Okay.
7 days.
Yeah,
Okay.
yeah, 7 days. Yeah. So let me, yeah. So let me. So what you think you did fine, and what you think you might change in doing it.
I think I took a lot of kind of data gathering. It might not be needed, but I'm still unsure in result cases, like how much data gathering we need to do.
To be honest, I feel you did less that at the gathering than you should to, because I will tell you why. I will tell you why. Actually, you need to ask more. And I felt that you was a little bit shaky, isn't it? I felt that you asked a little bit up and then you went to the psychosocial, then returned up to ask about cancer. So you lost the structure a little bit, isn't it? I felt that. And I
Okay.
think you felt that as well, isn't it?
I did. I mean, you're
Yeah, you
right.
did.
I did
Yeah,
that. Yeah.
yeah, yeah. But that can happen in the exam, no problem. That can happen in the exam, and you can just save it. Say, I meant to ask you, I should have asked you about this and that, and you can save the structure. What else? I felt you are skipping some of the patient questions, and that's not good. So I'm keep asking you, well, how I get it? Did I transfer it to my this? It was a little bit hesitating. Then I told you that does this, I read that this bug can give me a cancer. Does that true? That can I get a cancer? Then you skip. You said, oh, chronic gastritis can cause a cancer. Um, I think
Okay.
you are not sure about the answer. That's why you try to escape.
Maybe
Is it?
yes. Yeah.
Yes, yeah,
Maybe
but
yes.
yeah, but that's not good in the exam. If you are not sure about something, say I will look at it and I will come back to you. Not to try to escape and ignore the patient, because his question was not saying that if I have a gastritis I will get a cancer or not. He was asking if I have the bug, would I get cancer or not? Which that
Right.
can lead us to a big dilemma, because there's people that have H. pylori positive, but at the same time, it doesn't have symptom of gastritis. So to treat or not to treat, which is a big dilemma in medicine. Okay,
Mm.
usually we prefer to treat because H. pylori by itself is connected to multiple cancer. One of them is called MALT cancer, which is one
Mm.
of the non-Hodgkin lymphomas. So, so yeah, you need to tell them, yeah, well, yes, H. pylori is connected to having on the long run cancer, but the good thing is we did discover it now and we will treat it and we'll come on top of it. So reassure him. Okay. What else you think you might do different?
Maintaining structure. Maybe I need to do something about sertraline as well.
Exactly. Yeah. Well, it's clearly written in the patient note, serotonin for situation and anxiety.
So
Okay.
you can.
So yeah, you need them to look at it and say situation like that. Does he need the sertraline? Does sertraline, have contributing in the patient symptoms, which can be the sertraline can cause the gastritis to become worse, isn't it? So
Mm.
sertraline need to be addressed at this situation. And if he would told you, well, I use it only when I was preparing for my final exams. He's newly qualified accountant, so he was using it only when he was, approaching his final exam, when he was feeling stressed. So they prescribed for him sertraline. So he have an anxiety from exams. Okay, so it's not unwise to use sertraline for such indication short term and then stop it. So he doesn't need it. He need to stop it, especially if you ask me, okay, I'm happy with my new job and I don't have stresses and everything, and my family is fine. Why I'm telling you, you need to ask more in your history taking, because unfortunately your colleagues here didn't do a great job. So they didn't give you any sufficient information. That's, for sure they did exclude, risk factor of cancer. They did exclude indication of endoscopy. They did exclude the possibility of having, red flags, but nothing was written. So all the other consultation, nothing is written here about the red flags. Then you need to revisit that. They didn't try, so these are missing bits in the story. So if there is missing bits in the story, and this is the difficulty of, investigation case, because you need to have full picture of the story. Sometimes they will give you missing pieces of the story, and then you need to dig further on. So either in the blood test itself, maybe there is missing bloods they didn't do, and you need to do, or missing, documentation about red flags, or even in this, further investigation or family history, they didn't document. That's why here they didn't document anything of the red flags, and even they didn't confirm is it true gastritis or not. Well, is it true gastritis? Is truly he have gastritis? And that's why it's good when you started to ask, do you have any back pain? So you are excluding pancreatitis, but does he cough? This is something related to his lung. And, does the pain is cardiac pain when he said burning pain? The pain going to his left shoulder? Does he have, is becoming wet, clammy, sweaty? So a little bit of, of questioning regarding, the other differential. Is it true gastritis or not gastritis? Okay. And then, little bit of the red flaggings, and then going, to the psychosocial and the ice. So psychosocial wise, you did ask a little bit about smoking, and he told you he's not smoking. And he asked about the irritant, but you missed one of the most important thing, that please, no one to miss asking about non-steroidal or over-the-counter painkillers. Okay, and then when he told you I'm drinking alcohol, I didn't hear what you said, you did, and I told you, yeah, I'm drinking alcohol socially, but not much, but you didn't ask about what does it mean socially, yeah? What is socially for me is different than socially for you, okay? And even if you told I'm drinking once in a year in the Christmas, then, okay, are you binge drinking then in the Christmas? Are you binge drinking in the New Year? That's important to be elaborated. Is that right? That clear?
Yeah. Yeah.
Yep. So if we started from the beginning, so you did introduce yourself. I'm happy with your introduction. You did, but I'm not happy by pre-existing information use. Yeah, you use how can I help you, and that's something I strongly to avoid. Please advise you to avoid, and then in the closed question.
How should we start in result
Well, you
station?
will
Can you
tell him,
say that?
yeah, yeah. Well, you see, you have in the existing info. Yeah, I can see that you have a couple of visits, one 5 months ago, and the second is 4 months ago. My colleague, I think that you have gastritis and reflux. They start you on omeprazole. It doesn't give a sufficient response, so we are checking for what the bug in your stomach. Is that right? Okay. So, do you want to add anything? Okay. How it's been going? Any other symptoms appear from now until then, and start your conversation. Okay. And how's been going will save you a lot. Okay. So like that you're thinking, so if there is any change in your symptoms, so if you have full story and you don't want to dig more and everything is fine, and you want to double check if there is any change in the symptoms or the story that was written in your notes, then tell him how's been going. How's been going means is there's any change in your story or any change in your symptoms, and then let the patient talk, and for sure the actor will give you something. Okay.
Okay.
And then, so the closed questioning, we will go through it, okay, because you need to ask about, make sure it's gastritis or not. The other thing, make sure that there's no red flags. And I didn't hear you telling about, vomiting blood, or, or booing blood. You have, bloating or not, I didn't hear any of these traits, right? You said only weight loss. And I think the problem is in your questioning. So you said weight loss, and then you remember that we should say unintentional weight loss. And then you said about nausea and sickness, but so nausea and sickness, do you vomit blood or not? That need to be close the question. You need to be specific and goal directed. So you can take, you can take the boxes for your differential. Okay.
Okay. Thank
And
you.
also with cases of gastritis, you need to, so this patient is not only gastritis, okay? This is a medical term was called dyspepsia, because he have gastritis plus reflux, yeah? You have GERD symptoms as well. He told me I have burning sensation in my chest. So it's not purely gastritis, it's gastritis plus reflux, with a medical term called dyspepsia. And then you tell him you have this inflammation in your stomach, and as well as it seems that the acid secretion is returning back to your food pipe and causing you these symptoms. However, it's very common and we can do a lot about it. And I think one of the main contributing factor of your symptoms is the H. pylori. However, we can treat it easily, and then we'll see if our treatment is effective or not. And talk about the treatment and then the other things that we can do. That you are saying that you are trying to lose weight. I'm just wondering if your weight, what is your weight is, and you need to be referred to the weight management services. We can do that, but also you need to stop the coffee. What's your thoughts about that? With decaffeinated coffee, yes, decaffeinated coffee is less harmful than the full dose coffee, isn't it? But still, it has caffeine. So you just tell him, yeah, because he might be drinking 2 cups of coffee, okay, and then he will go and drink 10 cups of decaffeinated coffee. So we didn't do anything then. Yeah, it's the same. Yeah, so always try to guide him. Yeah, yeah, decaffeinated coffee, less coffee, but it's not a caffeinated coffee. It's decaffeinated. I mean, there is some caffeine there. Okay, and yeah, you said about chocolate. You didn't. I didn't hear you addressing the alcohol. Yeah,
I didn't do, yeah.
yeah, which is fatal. Yeah, so that's important. Don't forget addressing the alcohol. Okay. Uh, 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 uh. The other thing, so in the management, so if it's gastritis, you need to tell him that. So what other things? So you didn't ask him also about when his meal is, yes, that he wear tight clothing or not. So you can just tell him elevation of the head of the bed. All of that need to be addressed, isn't it? And it's
Mm.
good, yeah, you said clarithromycin. I think it was fine that you said the name of the medication because every medication of this have his the dose and so you might not have time to say all the doses, but if you get time to him, I will send you the doses in details, okay, and it's 1 week, not 2 weeks. The queries that he just throw you with, okay, we said one about the cancer. We said from where he get it, and we said the fecal roots, yeah, or contaminated food or contaminated drink. The other thing, that can he give it to his girlfriend? So you said no. I will just ask the other doctors. What if anyone can answer, doctors? Is it fine? Is it fine people to participate, please? So it will be more conversational educational event. So did anyone know? Is there is any way that the H. pylori to be transferred to your partner? Doctors, anyone want to
Through
Depending
saliva
on
testing.
the nature of the partner, is it a male partner or female partner, and what sort of sexual activity they are doing, that could be a possibility of passing on. So clarifying with that.
Yeah, well, to be honest, it's not related to what type of partner, okay? Because it's not sexually transmitted, but it can be transferred. I think some other doctors say
It's
saliva,
a
Yeah,
isn't it? Yeah,
kissing.
saliva, yeah.
yeah,
Yeah,
kissing. So
by kissing, it
kissing.
can be transferred.
Yeah, so kissing or using the brush of your partner or something, that's all it can be. So if you want, if his partner have symptoms or want to be, tested, that also, a possibility. Okay, and the safety netting was done. Retesting. So do anyone knows when we can retest the H. pylori, when it's indicated?
If it is no response to treatment,
Yeah,
or if the symptoms recur, and it has to be done at least 4 weeks after, ideally eight
exactly.
weeks.
Yeah, exactly. From all 4 to 8 weeks, then you can repeat. And there is certain, indication if the patient is very old, having history of stomach cancer, or persistent of symptoms, or gastric ulcers, or prevalence from high, from high prevalence area. Okay, so like East Asia, all of these countries having high prevalence of H. pylori, so you can retest just to make sure that the test the patient is cured or not. Okay, so how I'm thinking in any case of
Sorry,
gas,
Dr. Salem. Sorry, I didn't
yeah,
get the timing to repeat. Did you say after 4 weeks?
yeah, from 4 to 8 weeks.
Okay, thank you.
Yeah, yeah, no problem at all. How I'm thinking in case of gastritis, if it came in the exam or even in real life. So I'm thinking it in 3 or 4 steps. First, if it's true gastritis or gastritis mimic, okay, so is it something coming from, because the stomach is in the thoraco-abdominal area. So thoraco-abdominal area, this can be something in the heart, something in the lung, okay, or truly coming from the abdomen, and that can be either from the stomach, either from the pylori colic, or or even IBS or pancreatitis. So in your differential, you need to clarify that in your asking. And then after that, you are clearly know that it's gastritis or reflux symptoms. Okay, don't also forget to ask about colon symptoms, because that will be important in the management. Because if you have a colon symptoms, I will tell you what you need to order. The other thing, you need to see the red flags, okay? And the red flags that the patient over having hematemesis. Does he have a family history of cancer? Okay, does he have any weight loss or epigastric pain or epigastric mass even? So such case that's only been seen over the phone. This patient have only the 2 consultation was over the phone, was never been advised to come and and be examined in the clinic. Well, I would rather, I will start the treatment, but I will invite him, at some point to just feel his tummy and examine him and make sure that we are not missing any mass. Because if he have H. pylori, this doesn't mean that he might have other things, Okay? Especially that no one document that they examine him. All the investigation was, all the talk was over the phone. The other step after red flags, then does the patient need routine or urgent, endoscopy referral? So does he have any hematemesis from before, any past history of hematemesis, or if he's more than 55 and having, persistent epigastric pain, or having reflux symptoms that is persistent to the treatment. And we will come in details what are the indication of the referral in the slides. I will come to the slides in a minute. And then after all of that, if there is colonic symptoms, okay, so asking about the causes, and for sure, don't forget non-steroidal, alcohol and lifestyle. And then ask also about colonic symptoms, because if there is colonic symptoms, you might add serology of celiac disease. Okay, if you have a change in the bowel habit, you will need to put fit testing. Okay, and then look at so this case, if we look at the blood test, they did only liver and and full blood count. So does he need fit tests? We need to ask a few questions. Does he have abdominal distension or change in the bowel habit? Then we might also adding celiac disease screening. And then in the test, in any general gastritis, don't forget to put full blood count, because when the full blood count return, you need to look at 2 things. You need to look at the anemia, because if the patient anemic, that might be considered, referral for endoscopy. And also if you have high platelet, that can be a clue that patient may have a cancer. Okay, if a female, okay, I would also ask about early satiety and abdominal distension for CA125. Okay. Is that clear? This is how I tackle the case, and then go ahead for treatment, test or treat, or to test and treat, or treat and test. It depends. It depends on the indication. Is the patient high risk of having H. pylori? Then I will do test first and treat. If the patient, low risk of H. pylori, then it doesn't matter. I can have either approach. And we will discuss what are the cases that it's preferred to do test and treat first. Okay. I will open. Does anyone have question for what I said? How to approach the case of gastritis? It's few steps. There's not much. Is it fine? Shall we go to the PowerPoint? Okay. Do you see the PowerPoint, doctors?
Yes.
Yeah. So these are general definition of what does it mean dyspepsia. So as we said, dyspepsia mean the gastritis symptoms of heartburn plus reflux symptoms, plus or minus nausea and vomiting and the bloating. And then after the endoscopy, if it's indicated to be endoscopy, the patient to have endoscopy, we have 5 categories. Okay, either functional dyspepsia. Functional dyspepsia mean the patient, when we did the endoscopy, we didn't find anything, and this will consider 80% of the patient. Or we have gastroesophageal reflux disease. Okay, either severe gastritis or esophagitis, or severe esophagitis or reflux of esophagitis, or also functional reflux esophagitis, or having a stricture, or even you can have a Barrett's esophagus, and this will have later on a different lecture of Barrett's esophagus and how we should tackle it in the primary care. Okay, or we have peptic ulcer disease, like duodenal ulcer or gastric ulcer, in the 8%, and less than 0.5% that are having, gastric cancer. Okay, this is how we can approach, and I already explained the 3-phasic or 4 phases of reaching gastritis. So in this diagram so it's the same as the 3-phasic structure, how to attack, how to approach gastritis, but just here reminding you about the referral. So if you're having hematemesis or current GI bleeding, you need to immediate admission, or if you have abdominal mass or say, consistent with gastric cancer, then you need 2 weeks wait pathway. And then if you have dysphagia or difficulty in swallowing, so this is direct upper GI. And then according to the age, if he's above 40, so 40 started with F, then it's connected the family history. So if the family history of gastric cancer or esophageal cancer, okay, or from area with increased incidence of gastric cancer, that like East Asia, then that an indication for direct endoscopy. And if it's more than 55 with weight loss, dyspepsia and abdominal pain, that also indication of direct endoscopy. If above 60 and having abdominal pain and weight loss, we are doing direct CT scanning. Does anyone know why? If the patient above 60 with abdominal pain and weight
Pancreatic
loss,
cancer.
pancreatic
Pancreatic
cancer,
cancer.
Okay.
yeah, pancreatic cancers. And that's why if any patient above 60 have new onset diabetes, what you should do?
CT scan.
Urgent CT.
Urgency, yeah, urgency. Also, that's a potential. Okay, so don't, yeah,
With
that can come. It's a new onset patient with diabetes. Okay, and coming, to discuss the results. Okay, so you need, when you are talking with the patient about the result, you need to make sure that he doesn't have symptoms of pancreatic cancer.
with
Okay, and
with new onset diabetes and more than 60-year-old, do they have to have weight loss before we request CT?
yeah, they have symptoms. Okay, so gastric pain, and weight loss. Also, if you have symptoms, okay, yeah, you need to consider. Okay, and also, and also do some blood testing. So you need to do the liver function, okay, and see the CRP. So if the CRP is high, and there is some symptoms, then you need for sure to investigate the new onset diabetes. Okay, for sure, not everyone with new onset diabetes at above 60, you will just send him to the CT directly. You need to ask him and see, and see the clinical vignette. Because if you have a pancreatic cancer causing him diabetes, he will be symptomatic somehow. Okay. And at least you can order ultrasound scan. Okay. And I met in my career, okay, up till now, 3 cases coming with new onset diabetes above 60 and having, pancreatic cancer, and one of them lastly was pancreatic lymphoma. Okay, it was pancreatic lymphoma, which is very uncommon. So it was lymphoma, unfortunately. Okay, and then after all of that, you do either you will give trial of omeprazole or PPI for a month and reassess. And if the patient doesn't respond, so you need to do the H. pylori. And what type of H. pylori testing we have?
We have mainly 3 tests: the stool, the blood, and the breast test. So
Yeah, but yeah,
most
what is the
accurate-
difference? Yeah.
but I think the stool test, it will be affected by the medication. If he's on omeprazole, for example, or antibiotic. So it's, if you want to follow up with this, it's not, you have to stop the medication for a long time, then do the testing. I think the most accurate one for follow up or follow up eradication of the bug or the H. pylori is doing the breast test. I think is the most accurate one.
well, still the breath test, to be honest, the breath test still can be affected by the PPI, and even breath test is affected by Gaviscon. So better to do the stool testing because you need still to stop, and even H2 blockers sometimes would be affecting the urea breath test, and it's a big hassle to be honest. You need to drink the active carbon, wait in the lab, and then give a blow in the machine. So it's usually most of the lab people will avoid it. Okay, I locally in my area we don't have the urea
I
breath
don't
test.
have it as well. It's just, as as general. But I think NHS they don't support
You didn't say,
them.
okay, yeah, I
I
didn't
don't think
say,
so.
yeah. For sure, avoid the H. pylori antibodies because serology doesn't mean that there is an active infection. It's an antibody. So he might have the infection and his body clear it. So it's always, avoid the serology, okay, because it's always debatable. But the stool antigen and urea breath test are more accurate, both of them. But, the stool antigen is easier to be done, and both of them you need to stop the PPI before doing it. If the patient will give him PPI, the response is not sufficient, and then he's telling you, "Oh, doctor, I can't stop the PPI to do the stool testing." So what you will do? How can I stop the omeprazole, doctor? Is hardly I'm hardly coping.
We can give famotidine.
Yeah, we can give famotidine. Yeah. Did anyone know why ranitidine was removed from the market?
Carcinogenic.
Cancer.
Yeah, well, to be honest, it's not the ranitidine itself, but when you are when the form, the infrastructure or the molecular structure of ranitidine containing, when they are forming it, it need to be contaminated with one of the chemical substance in MD, and this chemical substance is the cause of the cancer. So it's not the ranitidine molecule; it's the way that how we are sensitizing that. So if we find a different way of sensitizing that, then I think ranitidine will be the best because it's the cheapest. So maybe in the future they will be able to, to formulate ranitidine in a different way, and then we can restart using it again. Because the problem with the H2 blockers now is very expensive, in comparison to the PPI. So one course of famotidine per month is costing the NHS around 27 to 31 sterling pounds. One course of omeprazole will cost, 1 to 2 pounds, so a big difference, and that's why now the H2 blockers is out of fashion. But still, sometimes you will be pushed to do it. One of the scenarios is this: if you want to stop, the PPI because you need to do the stool testing, then you don't have any other choices other than giving H2, especially if the patient cannot tolerate the symptoms. So every patient coming to you after having an endoscopy, oh doctor, this doctor in the hospital, he didn't explain anything to me. He did the endoscopy and I'm not sure what is going on. So the patient have symptoms of gastritis. They did the endoscopy and there is nothing in his stomach, and they diagnose him as functional dyspepsia or functional gastritis. How would you explain that to the patient? So how you will tell him what is functional gastritis? So for the people who are struggling with the explanation, so how you will explain functional gastritis? Anyone can volunteer, or even Sophia, because she was doing the case. So Sophia, would you be able to volunteer to tell us what is functional gastritis is? Or how you will explain to the patient functional gastritis?
Um, it is a condition in which there is inflammation, in which you can have symptom of gastritis without any cause. I don't know.
Well, how you will explain to the patient irritable bowel syndrome? It's the same concept. All these diseases have the same concept. How you will explain irritable bowel syndrome? How you will explain, unstable pelvic syndrome? How you will explain pelvic pain syndrome? Okay, how you will? So I can see. Yeah, who's raising his hand? Yeah, he can answer. Anyone? Yeah, go
Yeah.
ahead, doctor. Yeah.
So on doing the test, it's a condition where we don't find any obvious abnormalities in the structure of your stomach or your food pipe, but
Mhm.
still you are having symptoms, or your body is like reacting in a way that there is no obvious abnormality s- that can be explained.
Then the patient will be lost.
Okay.
Yeah, really abnormality, and I will feel confused if anyone can have another try, and I will tell you my own explanation.
So I would say that everything, the camera test which you had, uh, everything on the lining of the your stomach looks absolutely fine. It's just that the hydrochloric acid is secreted in our stomach, which is required for our digestion, and sometimes the secretion is more. Like for example, if we are under stress, or if, if we like if we have, or if there is history of alcoholism, smoking, or especially if he's under stress, or if we are under stress, the hydrochloric acid increases. So I'll explain like
Yeah,
that.
yeah, that's, I think, a good explanation. Well, I would say any functional disease, okay, even the IBS, because it's functional disease. I would say, well, there is a miscommunication between your brain and your gut, for example, for the gastritis, and which make your brain resilient to stress, okay, and your gut more sensitive to some food, certain type of food, and that will make you secrete more acids. Okay, is that clear? And how do you think, guys? Is that will be clear for the patient or not? Yeah, Dr. D, Dr. Tawfiq, I think, raise his hand.
Yeah, I would just add to this,
Yeah, sure.
uh, I mean, we have done the camera test. There is nothing
Yeah,
abnormal in your gut.
yeah,
We
sure.
haven't found anything. However,
Yeah, sure.
your symptoms, I believe that your symptoms are genuine. And it's more related to your brain gut miscommunication, as you said.
Yeah.
And the more you think of it, the more it brings on the symptoms. So it's better if we can try to break this cycle of thinking. So I think there's some sort of, we can later offer him some sort of CBT
Yeah, sure, without doubt.
that break
Yeah.
this
Yeah,
cycle.
without doubt, without doubt. CBT can be offered. Okay, you can. That's why you are using also amitriptyline. So that's why the concept behind the amitriptyline in IBS. So why we are using amitriptyline in IBS? The same as in functional dyspepsia. By the way, we still, if you give him omeprazole dose and the patient is not improving or still having, some symptoms, you as a GP can still start him amitriptyline, and the amitriptyline dose will be 10 up to 50 milligrams, and then not forever. You need to review the patient from 3 to 6 months and see if you can withdraw the amitriptyline. So this one of the treatment, the functional dyspepsia, is important. That diagram just to remind you about the possible differential diagnosis of epigastric pain like gastritis, and we said heart problem, biliary colic, or even pancreatitis. Also, how to differentiate between the duodenal and the gastric ulcer. Usually the pain of the gastric ulcer, the duodenal ulcer, is after the transit of the stomach. So we know that the stomach, when the food enter to the stomach, will be a closed box. So the gastroesophageal reflux will close, and the gastroduodenal reflux will close, and then the stomach will squash the foods inside it, and then after about 2 or 2.5 to 3 hours, the gastroduodenal sphincter will open, and then the transition of the bolus of the food will go from the stomach to the duodenum. And then if there is a duodenal ulcer, then the pain will start after that, so around 3 hours after food. But if it's gastric ulcer, then it will appear once the food reach the stomach, which it will be around 1 to 2 hours after eating. Okay.
Dr. Salim,
Yeah, go ahead.
sorry.
Yeah, can you,
So you said
who's with me?
functional,
Yeah, who's
Samra,
with me? Okay, Dr.
Samra.
Sama, go ahead. Yeah.
So you said functional dyspepsia. I understand the brain and gut association. So what if patient says that, yeah, I understand, doctor, that this is, you're saying it's functional, it's some association with my brain, but how do I manage it? It's just affecting my quality of life. Like, I
Yeah.
just keep on omeprazole for whole of my life?
No, no, well, for sure, no, and that will send us to the other question. Okay, what are the indication of long-term treatment of omeprazole, so or PPI. So I will answer you, the Dr. Samra. Don't worry, because if you wait until we go to the next slide, this would be the answer of your question. So
No
for
problem.
sure the functional. No, I will answer you, and then we will go to the slide. So the functional dyspepsia, yes, there's no risk of cancer, no risk of this and that, and no red flags. But then you need to empower the patient to control his treatment. Okay, so you need to give him the omeprazole and review him until you reach the proper dose, and then you will stay for a certain time, plateau time, until you control all the symptoms, and then you will gradually withdraw the PPI, and then give him the power that if anything happened to a change of the symptom, give him the red flag. You need to come back to you, as well as you need to tell him, you might use the PPI on demand, because we know long-term use of PPI has an own risk. So it causes osteoporosis, it causes hyponatremia, it causes hypomagnesemia, and me personally saw a lot of people having VTAC and VF because of the hypomagnesemia of the PPI. And in the GP land, we are not seeing this, but if you work in the emergency land, you will see hypomagnesemia induced by PPI causing VTAC and VF. So putting the patient on the PPI without clear indication is harmful for the patient, and you need to explain that to the patient, and to have shared understanding and shared decision making between you and the patient, so he will know you are not removing his PPI from his medication if you are doing review medication because you want to save the money of NHS. No, we want to save your health. There is a problem from that medication if there is no clear indication for long-term use, and you can't tolerate the symptom or using the PPI on demand. Then it's better to remove it from your repeat, and I will prescribe it to you whenever you want it. Whenever you finish the box that I'm giving it to you, then I call me and I will write another one for you. No problem for that. This will not cause us any problem, but we need to save your health. So you need to teach him what is the red flag. You need to teach him when to use and how to use the medication on demand, and gradually withdrawal the medication, so we will not have rebound gastritis. And we will come to the way of deep prescribing of PPI, because there's one slide just dedicated of the deep prescribing of the PPI. But coming to your question, Dr. Sumira, and just can you tell me or anyone, do we know what are the four category of patient that they need to be on PPI for long term? Because not all the patient, and that's what I want you to come out from this lecture. So when you are doing next time your medication review, I need to think, and you see PPI in front of you in the repeat medication for the patient, I need you to think, does this patient need the PPI or not? Shall I remove the PPI for the patient or not? Shall I start to do some patient education and tell him, well, this PPI is not as good as you think, and we might consider just using on demand, and educate the patient and see. It's a matter of trial and error. Some people will be fine by removing the PPI. Some people no. The symptoms will persist, and then you need to return him on it for long term. But at least you did what you think it's best for the patient. So do anyone know what are the indication of long-term use of PPI?
I think parrots, one of them.
Yeah.
Some
Well, to be
guys.
honest, it's not only parasites. Anything in the esophagus is one of them. Because the problem in the esophagus, the lining of the esophagus cannot stand the acid of the acid secretion from the stomach. So we have squamous epithelium in the upper one third, I think, upper one third of the esophagus, and then the columnar, the squamous epithelium is gradually withdrawn to become simple columnar epithelium in the lower one third, which is completely irresistant to the acid. So once you have severe gastritis in the esophagus, or ulcer in the esophagus, or restriction in the esophagus, then any esophageal problems, especially severe gastritis, they need to be on long-term PPI. If it's mild gastritis, then you would consider removing the PPI. Okay, what else? Well done. Is this are you Dr. Ahmed or yes?
Yeah.
Okay. Go ahead, Dr. Ahmed.
And Zollinger-Ellison
Yeah,
syndrome.
Zollinger-Ellison syndrome, yes, which is, the tumor in the in the G cell of the pancreas, because the G cell are stimulating the parietal cell in the stomach to secrete, the HCl. Yeah. What else?
What else? I'm not sure.
Yeah, eosinophilic.
On
Is a,
antiplatelets.
sorry?
On antiplatelets.
Yeah, but this is if dual antiplatelets or
Yeah, it's to be honest, it's not 100% antiplatelets. Okay, if you have a gastric ulcer, if you have high risk of GI bleeding, so either in antiplatelets and you have high risk of GI bleeding like very old age, or using a non-steroidal. So if there is high risk of of GI bleeding, then you will need to add them. And in the NICE, although the NICE guidance is not nominating that sertraline and SSRI high risk of GI, although they are, but they are not recommending that to be used as a routine. Okay, but if the patient have high risk of GI bleeding, like chronic use of non-steroidal, if the patient have chronic osteoarthritis and he cannot live without the naproxen or ibuprofen, then unfortunately this is an indication of the PPI. Although I don't like using non-steroidal for long term, but it's a common practice. Yeah. What else?
PUD,
Total
peptic,
steroids.
Long-term
Using
steroid
steroids.
peptic
or
ulcer.
condition like PMR.
Well, could be. Okay, yeah, steroid, one of the things that increasing the risk of GI bleeding. Yeah, especially if he's symptomatic. So, and what else?
PUD, peptic ulcer disease.
Exactly.
on
Peptic. Not colbidogral per se alone. If you have high risk, you have risk of bleeding plus colbidogral. So I mean, if he's like in his 30s and he's on colbidogral, then I won't put him in PPI, to be honest. Okay, well, still you can have people having MI and stroke in their 30s, but does he will need the PPI? I doubt it. If he's if he doesn't have gastritis induced by colbidogrel, I won't just put it routinely. Okay. Um,
I think also,
yeah. Go ahead.
I think also maybe hiatus hernia if no surgical correction.
Well, the problem is hiatus hernia. Hiatus hernia is if it's symptomatic to that degree, I would rather to send him to for endoscopic surgery or something, to try to treat him. Okay, rather than just keeping him PPI. I would ask the, especially if he's young age, I will ask the gastro team to have a look at him and give us an advice, rather than just keeping him on PPI. And and also I will try to let him lose weight. I will try to to let him do the head elevation while he's sleeping, because I find it unfair just to put him in PPI. But it is one of the indication if the gastro team didn't proceed for any surgical intervention. Okay, the eosinophilic esophagitis, and if the patient have idiopathic pulmonary fibrosis, so idiopathic pulmonary fibrosis will worsen by the reflux disease, by the microaspiration of the acids, and will deteriorate the pulmonary function test. So it needs chronic suppression of the acids. So these are the four categories. So esophageal condition like severe gastritis, ulcer or stricture, high risk of GI bleeding, like chronic use of non-steroidal anti-inflammatory drug, and high or moderate risk of bleeding. Also, some syndrome with Zollinger-Ellison syndrome and eosinophilic esophagitis, idiopathic pulmonary fibrosis, or the history of gastric ulcer or duodenal ulcer. And when you are trying to withdraw the treatment, the symptoms will come again. Okay, according to the NICE guidelines, either to remove it or either use the lowest possible dose. If you are working in the America or Canada, so it's an indication for continuous use. Okay. Okay, so here what Dr. Sumira was asking, yeah. So what is the drawback of the functional dyspepsia? So it doesn't affect the mortality, but having negative impact on the patient itself and having negative impact on the on the surface because the seeking behavior from the patient, because he will be always worried. Okay, and the one of the causes of the functional dyspepsia, you need to be aware about it. Yeah, all of these are causes, but this one, because this was new for me, to be honest. So if the patient have acute infection, so acute gastroenteritis, sometimes can cause, a long-lasting functional dyspepsia. So if the patient coming to you after severe gastroenteritis, and he's suffering, don't just accuse him that he's malingering, okay? Don't be judgmental, doctors. Okay, and then so functional dyspepsia, and this is what Dr. Samira was asking, or Samira was asking. So how we will treat him? We'll keep him for long-term PPI or not? So the aim is to self-empower the patient, okay, with the red flag, and and to use the PPI on demand. Some of the lifestyle modification that you need to to give to the patient. So weight reduction, smoke cessation, avoid chocolate, caffeine, and fatty foods. Also small frequent meals, head elevation of the bed. Try to avoid the last meal before bedtime by at least 3 to 3 hours. Okay, and exercise and food map dieting. um One of the things is, encourage the patient to sleep in his right side. Okay. So, yeah, so here our prophet told us to sleep always in our right side. Okay. So you can see this is written in the guidelines as well. So right side is helping the stomach, the gastroesophageal sphincter, okay, to be tightened, because when you sleep on your right side, okay, that will make the angle of the gastroesophageal sphincter, yeah, to be tightened. Okay, so always try to think in the guidance and correlate it to your own beliefs, doctors. Okay. um yeah, tight to clothing. Okay, and chewing gum. Okay, chewing gum will help because it will
Alcohol,
decrease the
coffee,
reflux.
fizzy
Yeah,
drinks,
yeah, and fizzy
red meat,
drink.
chocolate. It's all, and maybe
Yeah.
try and sleep.
Please, can you say again? I didn't get the reason why we sleep on the right side of
Okay, I will show you in the fake photo. Don't worry, I will show you. There is a photo I will show you. Why the sleeping in the right side will prevent the reflux from happening. Okay, when I come to the fund duplication, how it's done, I will show you why the right side is important. Okay. And then also don't forget some medication as are entitled for the reflux disease. Okay, non-steroidal, calcium and opioids, biphosphonate, okay, corticosteroid, thiophenyl nitrate. Okay, and don't forget, although TCAs are helping the functional dyspepsia, also it's accused of increasing the gastric reflux. So, just try to think if the patient will improve from it or not. If not improving, that's why we're reviewing him after 3 to 6 months. Test and the treat, or treat and test. Okay, and here the peptic ulcer disease, lymphoma, and gastric cancer. Okay, these are the indication of test and treats, which are old population, patient from North Africa, patient living in high risk areas, or patient having iron deficiency unexplained with anemia, peripheral gastric or duodenal ulcer disease. Okay, all of this, go through test and treat. Don't wait to treat and test. When to repeat, as we said, persistent symptoms. Okay, patient have duodenal ulcer, gastric ulcer, or perhaps high risk of having multi syndrome, multi lymphoma. Okay, poor compliance or high locality of resistant areas. Okay, or taking aspirin without co-prescribing of PPI. So these people need the test of cure. These are the algorithm that we took. So if the patient having, doesn't have any allergy to penicillin, then you are treating either with CAP or MAP. So CAP, clarithromycin, amoxicillin, and PPI, or MAP, metronidazole, amoxicillin, and PPI, and the dosing is there. And then which one to use, clarithromycin or metronidazole, you will see which one was used recently. So if no one used recently, any one of them, or if one used recently, then you just use the other one. And if the patient have allergy from amoxicillin, and then you can use CMP, so clarithromycin, metronidazole, and PPI. I don't think it would come more complicated than that, because it's difficult to remember all the regimen. But however, you can say to the patient, yeah, well, I think that these regimen are not sufficient for you. There is other regimen that I need just to review the guidelines, and I will send it to you, and I will give you a call at the end of the day to discuss further. Okay. And just go to the guidance and bring, whichever is sufficient there, and write it for the patient. Okay, so this is the functional dyspepsia and the indication of the amitriptyline. And then if the amitriptyline is not sufficient, then you can refer to the secondary care, and they will give more investigation, your MDT meeting, or giving CBT, or even trying some antipsychotic for the treatment. Okay, coming back. So this is the Io, yeah, Io was asking why, if we slept on the right side of the stomach, why the sphincter will be more tightened. So we can see this is the right of the patient, and this is the left of the patient. So you can see that the esophagus, when it's entering through the diaphragm, if you can see, the diaphragm will be here. So when the esophagus is entering through the diaphragm, is entering with an angle. Okay, it's not straight, and it's not toward the right, it's toward the left. Yeah. So if you slept in your left side and you slept in your right side, you will bring the antrum of the stomach and the rest of the stomach to the right, and that you will tighten this area. So you will tighten this area. And that's why if you slept in your right, that will make the reflux less prominent. Is that clear? It's all mechanic.
Yes, thank you. I got it.
Yeah.
Thank you.
If you slept in your left, it will make the things worse, because the antrum will just come here, and then the angle of the entrance of the esophagus will be in the same line of the antrum of the patient. Okay, and that will make all the fluid on the stomach will be easily go up. So that's why sleeping on the left side is not promoted. Okay. How the fundoplication is done? So it's keyhole surgery. Okay, it's not a major surgery, it's keyhole surgery. And all what they do, they bring the antrum and just wrap it around, okay, the lower 1/3 of the esophagus. So there will be double layer of the stomach, and then that will make that, it will tighten the lower esophageal sphincter, and will make the symptoms better. If a patient coming to you after fundoplication and still have the symptom, is this patient is truly symptomatic? Is that can be after fundoplication you still have gastritis and reflux esophagitis? Does anyone know? Did anyone meet patient with fundoplication and is still complaining? Does we need to believe, to doubt the complaint of the patient? Although I don't like the word doubt, because you need to respect the patient complaint, whatever the complaint is. But if it came to your mind, oh, what should I do? This patient, we give him PPI, we give him this, we give him that, we even do the operation for him, and he's still complaining. So is that can happen or cannot happen? Can anyone say? Okay, so and instead of fundoplication, 25% of the patient can come with the same, not the same, but with still some reflux symptoms, and you need to keep him on the PPI then. Okay, so if you see patient having fundoplication, there's not a clear indication to remove him from the PPI. If he's still symptomatic, keep the PPI. Okay, don't remove it. The patient truly symptomatic, he's not lying. Okay, there is 25% still will have symptoms. So the fundoplication just relieve little bit of the symptoms, but he might still having symptoms that need to be elevated by the PPI. Well, and all the practice, all the practice since I was even graduated back in Egypt, we used to do give brukinetic for the patient having gastritis. And then unfortunately, the brookinated that we used to use them, it's all of them are unlicensed for such indications, so don't use them. Okay, and in the UK, the old brookinated that are licensed for such indication is not available in the UK market. Okay, and these are the four brokinetic that indicated for gastritis or reflux esophagitis. So we have alerts that metoclopramide need to be avoided for the extrapyramidal manifestation. Okay, and it's not licensed for such indication. And also the dimperidone can increase the QTC of the patient. Okay, and the ranitidine, we already said the ranitidine is contamination of the NDMA. What are the complication of GERD? So what are the complication of GERD? Why you need to control the complication, the GERD symptoms, okay, other than the feeling of the patient or micro GERDs, okay? So please, if you have a patient with COPD, if you have a patient with asthma, allergic rhinitis, or persistent, tonsillitis that you are giving him penicillin, giving him that, and is not, responding, or even chronic cough, don't forget to keep in mind that he might have reflux, and these are symptoms of flux. And we did one case, the first case I ever did in the YouTube channel was I think the metallic taste, and we said that there is an extra GI manifestation of reflux, and one of them, by the way, is not only the metallic taste in the lupus hystericus or laryngitis or globus, and allergic or rhinitis, okay, or sinusitis or otitis media, as well as, okay, idiopathic pulmonary fibrosis. And if the patient having COPD, it can participate in the COPD exacerbation and can participate on the asthma exacerbation. So keep in mind, okay, these things, and also dental erosion. This is just because this table is just for follow-up patient. If the patient have PPI and what is the modification needed for his treatment, don't put a lot of effort on it. But the most important here, that also a practice that you might need to change, that why not, if the patient having peptic ulcer or gastritis, why not to try to use COX-2 inhibitor, okay, to come over his pain symptoms, okay, and you can always co-prescribe PPI with them. So alcoxia or is one of the things that can be prescribed. Melocam also can one of the things that can be prescribed in the patient having gastritis, and it should be safe, shouldn't make a problem for the patient. So if we have so painkillers is not like no for the patient that having peptic ulcer. Still, yeah, we have what's called selective COX-2 inhibitor. There is some other side effects which can be related to the heart and but it's worth using it for short course, even if you have gastritis. And the only way to see if it will affect you or not is to try and see, are you happy with that or not. If he's not happy, that's fine, don't use it. If he's happy, then you already did the shared management plan and you explained for him what is the possible side effects. Okay, any question? Because the Dr. VB, I think he wants to ask something. He removed his mic. Anyone want to any question? No? All are
I've got
fine?
some questions.
Yeah,
Hello, hi,
Dr.
can you hear me?
MK. Yeah, I know your name. MK is what?
Yeah, yeah, May.
May. Okay, Dr. May. Yeah, go ahead, please.
Yeah, so I've got a few questions.
Yeah, sure,
So,
go ahead.
yeah, so if we like to order stool test,
Mhm,
we stop the PPI
mhm,
and we switch to like famotidine if the patient has symptoms.
mhm, mhm.
Can we do the direct switch
Direct switch from PPI to famotidine. Yeah, you
to
can.
famotidine?
Yeah, you
Right,
can. You
okay.
can. You can.
And also, if we would like to win the PPI down and gradually stop it, if the symptoms are better, we need to win that down definitely to prevent the rebound symptoms. Is that correct?
we have three ways of de-prescribing, and this is in the last slide, but I can tell you, okay? The best one is tapering, okay? So gradually decreasing the dose of the PPI, okay, and then you can stop it, okay? Or using only on PRN. So what I'm do personally, I'm gradually tapering. So say patient on omeprazole 40 milligram, then I will put him in, 20 or 10 and 10 and 20, so 30 for a week or something, and then I will the other week I will decrease it to 20 and then to 10 and then stop it, and then I will tell him don't use the 40 or the 20 milligram except when you have symptoms. Okay. The other ways is to change directly to the He2A1, the famotidine directly, and then the rebound symptoms is 1 in 5 in such situation. But in the gradual tapering and the BRN, okay, the rebound symptoms is 1 in 10. So each 10 patient you will have one. The other one is each one patient you will have 5, and then the sudden stoppage is each one patient you will have each 2 patient you will have 1. Okay, so 1 and
Right.
2. Okay, so
Okay.
me personally, gradual withdrawal, and then use it as PRN, which I think you need to do this strategy with every medication, to be honest. Blood pressure medication, gradual withdrawal, and then see, okay, and any other symptoms, say the inhalers of the asthma. Okay, you are using steroid higher dose, then you are gradually withdrawing it to the middle dose, then the lower dose, and then you remove it and use the Ventolin PRN. Same concept. So, take that, this baby step concept, except if the patient is dying, patient is dying, then you need to take major step. If not major step, then in the GP land, use baby step. It take me a lot of effort to learn the baby steps, because in the emergency department, usually you are dealing with, you are giving all your army suddenly to the patient. You are doing all your medication at once because usually the patient is dying. Okay. But if you are in the GP land and the patient is stable, use a baby step approach. Okay.
Sure.
Yeah.
And just one last question
Sure,
about the
sure.
SCA case. Yeah. So I
So
mean,
which case? Which case?
the case that we did, the case that we
Uh-huh.
did.
Uh-huh.
Yes, about the partner. Do we need to tell the patient that his partner needs to have the H. pylori test done?
Well, you answer his question. Okay, the answer his question. His question is saying you, well, does my partner can have the infection? Yes, can have infection because it can be transmitted through the saliva or the toothbrush or even fecal oral route. Okay, does she need? Well, does she have symptoms? Okay, do you want, if she wishing to do blood stool test, we don't mind to do it. Okay, but it's not a must. It's not like you
No.
will, it's not like contact tracing. Okay. It's not like patient having meningitis and we need to know all his, contacts, and we need to do a screening for them. And it's not like TB case and you need to also to do screening for all the contact. Okay. If the patient partner wish, yeah, he can come. And you cannot
Yeah.
say no because there is a clear indication. Her partner is having H. pylori, for sure. They are having intimate relation, kissing, or using each other stuff. Then, or he's cooking for her, and who knows what his hygiene is. Then she, if she would like to be tested, you need to do it. Don't say no. Don't refuse it.
Yeah,
Okay,
sure.
but
Thank you so
it's
much,
not
Dr.
must to offer it. Yeah, not must to offer it. Okay.
Thank you so much, Dr.
No problem, no problem, no problem. Just here, well, the different doses of the PPI, there is no preference, to be honest. No preference between omeprazole, lansoprazole, pantoprazole. All of them have the same efficacy, okay? There is no head-to-head double-blinded study between each of them to say that one of them is better than the other. You are free to use any one of them, okay? And these are, the doses, okay? Usually when I'm in doubt, I'm opening the BNF, okay? But at least know one of them, okay? Omeprazole to 20, 40, and then sometimes off-license use, you can use 10, okay? And the other thing that is off-license, some people will be fine with the 40 milligram. omeprazole, but then he will tell you, oh, but I have nighttime symptoms. Yeah, and the BNF is once daily, but then you might consider using twice daily dosing. You can use 20 milligram in the morning, 20 milligram at night to alleviate the symptoms of the gastritis at nighttime. Okay, yeah, yes, it's claimed to be 24-hour basal acid suppression. Okay, the basal, the basal secretion of the acid suppression, but actually that's not true. Usually it's 12 hours or less than 12 hours. So you might do the 12-hour dosing, okay, regimen. Okay, but it's off license. You need to explain to the patient that's off license. Okay. Some of the side effects we said of the PPI is that can cause osteoporosis, can cause hypomagnesemia, vitamin B12, okay, but it's not routinely to be followed with, doing magnesium and doing vitamin B12, okay? But if the patient's symptomatic, just consider it. This slide is just describing the deprescribing. I just explain it from a few seconds, okay? Is there any question, doctors? Okay. Any questions?
There's a question going on, Dr. Salim,
Yeah, go
about
ahead.
the Gaviscon, that how long we have to stop the Gaviscon before we do H. pylori testing.
Well, to be honest, it's not 100% indicated. You can use it if you are using the stool testing, okay, the Gaviscon. So it's the PPI, but if you are in doubt, just to stop it 2 weeks. But Gaviscon, as far as my knowledge, is not affecting the results.
Thank you.
Okay, no problem at all. But bismuth is affecting, okay? So bismuth is different than Gaviscon. So if the patient is taking bismuth, he needs 4 weeks to stop, okay? Or if he's taking any antibiotic, you never use the stool antigen with patient taking a recent antibiotic. Any antibiotics need at least 4 weeks before the stool testing, and bismuth as well, okay?
Thank
So
you.
just be aware, doctors, that we have our channel, the YouTube channel. Please, if you are not subscribe, like and share. And as well as we have the WhatsApp group. Still, I didn't activate the Telegram group is there, but still I didn't activate it. I'm not posting anything on it. And be aware that I'm doing mini mocks and one-to-one teaching. I think is the most economical available in the market. And I promise I will teach you as much as I can. So if you need any help, please contact me. I did make a contest last week. I don't know, no one answered it. I know that by mistake, mistakenly I closed the answer for the question, but then I opened it since yesterday or the day before and no one answered. So I'm not sure. Do you want the answer of the question or to leave it one week more and see if anyone will answer? The price will be 1 hour one-to-one teaching for free with me for the first comment. So shall I leave it without answering the question, and you can answer not that question, the question in the facial nerve pulsing.
Here, the children and quinolone, is it?
No.
Okay.
The last, this one I will let you answer that if you can. Okay, but the last one, the facial nerve pulse, do you know the answer of it?
The
No?
last one, I don't know the last one. Sorry, I don't know the question either. I've just joined new.
Okay, so enter to the YouTube channel and see facial nerve palsy and try to answer the question. But if you know the answer of that question, and I'm happy to let you. So what are is the quinolone is, yeah, you want to answer quinolones? Yeah. So the question is, let me say the question first, okay?
Okay, no problem.
So the quinolone contraindicated in the children. I think that's an easy one. Okay. So if it's contraindicating, why? And is there any indication that we can use quinolone in the children when it's not contraindicated? Yeah, you can go ahead if you know.
Is it something to do with the joint or connective issue?
Yeah. Well, I'm not against that. I know that it's contraindicated, but then when it's mandatory. So when is that? What are the? So the question is, in another wording, what are the indication of quinolones in the children? Because you can use quinolones. There is indication of quinolones in the children.
Sure.
Do you know?
I'm thinking prophylaxis
Of
recurrent not recurrent UTI, sorry. Meningitis, Professor?
No.
Is that rifampicin, is it?
Mhm.
Not sure. Sorry.
Okay, so
I
the
think,
question is,
what about ear infections, Dr. Salim?
no, this is topical. I mean systemic.
Okay.
Topical, you can, but I'm asking about systemic for sure. Okay, so there is indication of quinolone, systemic indication.
Cystic
Hello?
fibrosis. Cystic fibrosis.
Cystic fibrosis per se, chest infection, no?
Yeah, if they have, if they are sensitive, like quinolones can be given. If they have
Yeah,
cystic
but
fibrosis.
but there is first line treatment quinolones for children. It's not like resistant cases, and you don't have except quinolones.
What about typhoid? That's salmonella.
No?
Uh,
Yeah.
I think there is a couple of indication for using quinolones in it. I think one of them, as I remember from chest diseases, that the patient is having multiple drug resistance from
TB?
the TB. Yeah.
Mm-hmm. What else?
Severe bone infection like osteomyelitis.
But again, you are saying if there is resistance, but there is one indication that you can use it without resistance. Shall I leave the question?
Pseudomonas infection as well.
Well, you have fourth generation cephalosporin to give it. You have phobixine. You can always give it. Shall I leave it for the YouTube channel, and the first answer, correct answer, he will win? Okay. But Dr. SB, I don't know. Dr. SB, what's your full name? Dr. SB?
Suresh Purnaswamy.
Yeah, so you are near to the answer. So if the correct answer was not there, then you will be the winner. So I will leave it until. Can you just send me hi in my WhatsApp? Okay, and then if no one answer it until next week, then I will give it to you. Okay.
Thank you.
And then
Thank
please someone to answer facial nerve palsy. Okay.
Okay.
Someone to try the facial, Dr. Ahmed, to try the facial nerve palsy, but still not try it.
What's the question for the facial now?
No, then you need to see the video.
Oh, fine.
See the video, and then you know. And Dr. Ahmed, do you want to try to say anything? Sorry, I think I cut you without intention.
My thoughts about it. That's
Okay.
there is anything sophisticated about it. I don't know. What's the difference between the cortical and supranuclear bilateral facial nerve palsy actually. I was thinking about
to be honest, it's not a question for GPs. It's just I'm trying to just to do brainstorming for the people.
I was thinking, I give my thoughts, about that's because the cortical is more generalized.
I will give you a clue. You can find the answer in a syndrome called locked-in syndrome. So these cases, because
all right. So
yeah.
I know that now. So
so look at the locked-in syndrome and then try to answer.
Is that the vertical eye movement only?
No.
Okay.
So such situation I met in my career when I was doing my training in the emergency and the critical care. Okay, so such cases you won't usually meet in the GP land, except maybe if you are having taking care of care homes that dealing with terminal.
I've seen one case. I've seen one case of locked-in syndrome.
You have seen, in the community, because here they have sometimes they are sending them, if the parents, able to take care of them, they will send with them a home mechanical vent, or even if you are taking care of a patient in care homes of the patient, sometimes you will meet them, and in such cases you might see such phenomena. But I will rather to leave it until you read about it, and then please by next week we'll answer both questions. Okay. And Dr. SB, please send me hi in my WhatsApp, okay? So if no one get the answer, then I will communicate with you and we'll arrange a teaching session between you and me, okay?
Sure,
I
sure.
will,
Thank you.
yeah, no problem, Dr. SB. You are ST3, your exam soon, Dr. SB? Your exam?
In March, not so soon.
In March, okay, no problem, Dr. SB, no problem. Thank you all for attending and to my lecture today. I'm very happy to see you all and hopefully we'll see you next week. Thank you, Dr. Sophia, for volunteering. Okay, and be brave to do the cases. That's that's very good. I wish you all the good luck of your exam. Okay, and please, if you have any question, just send me to my WhatsApp. I will answer you, okay, at any time. Take care, doctor. Have a nice night, and see you all. See you all next week. Assalamu alaikum. I'll just stay a little bit if anyone wants any question, so he can let me know. If not, I will leave.